Am I audible? Yes. Okay. So, hi, I'm Dr. Pavana, psychiatrist and NHCA mentor. The thing is, I should really thank Dr. Mittal for giving me an opportunity like this. And, I have been a mind coach. I finished my courses as a mind coach and also did my fellowship in child psychology and, multiple courses as CBT. And this, I should say, it has helped me tremendously in, improving my practice and, maybe increase my confidence and, whatever things I'm doing now. Okay, so let us start with the thing is, I'll take the session, say for about 30 minutes or so. Then we will take up the questions, and that could be in a mode of a chat. Okay, so any doubts, and please type it in the chat, and then we will continue with our whatever the rest over the sessions are. Okay, we'll try to finish it off, wind it down. Okay, so my outline, the learning for today will be what is OCD, what are the OCD cycle, how does it go about, so what is psychoanalytical theory and learning theory, biological aspect of it, diagnostic criteria as such, and what are the clinical features and treatment and psychoeducation, non-pharmacological treatment we are talking about, and behavior therapy, ERP, cognitive restructuring, and also not to forget that in how to apply in mind coach and what is the benefits of having an NHCA Singapore, CBT, how do we apply here? Okay, so coming to what is OCD as such. So we all know a gist of it, it's an anxiety disorder. See, we all have thoughts, we all have an kind of an intrusive thoughts, but when do we call it an obsession is whenever there is an unwanted, intrusive, persistent, which is very much persistent. Anything apart from thoughts, it might be any ideas or impulses or images, anything it might be, which we get it again and again. So these thoughts can be very distressing. Okay, so these are the, and also we should say that OCD is a component of both obsessions and compulsions. Obsessions are the mode of thoughts and compulsions are the act. Act might be as related to an obsession, maybe kind of in which decreases their anxiety level. That is, it should not provide a pleasure or a gratification. Like, for example, if I'm talking about an OCD cycle, there can be an obsession, a thought of kind of, for example, if I say a table is very dirty, a thought, intrusive thought, where the patient feels that, I'm kind of, it is too much. I should, I have touched it. My hands have become dirty. My hands have become dirty and there is a lot of germs in it. So anxiety mounts over time, and this anxiety is so much until and unless he performs some act in a sense of compulsions, what we call, that is maybe washing his hand or putting in hand sanitizer or anything which relieves his anxiety. So this anxiety is very distressing. It should not be anything of a pleasurable or gratification. So now coming to a psychoanalytical theory, why it is not for everyone and why some people have to have these kind of issues. So we can say that OCD, see, everyone cannot have an OCD, or we cannot say, okay, he is suffering from an OCD. Why few people only are, see, prevalence itself is 1 to 2% in the population. So what is that happens? Why do they have to develop an OCD? The one thing is weak underdeveloped ego, or an unsatisfactory parent-child relationship, or unconditional love, etc. This is one aspect of it. See, we all have known that in Sigmund Freud, as he told, there is an it, ego, and superego. It is something like an instinct of an impulse. For example, I have kept something on the table. There isn't something, a cake kept on the table. If I'm feeling hungry, it is an impulse decision, desire to have a cake. But my ego pops in and says, No, is it meant for you, or in someone else have kept, or do you have to ask them permission for it? Right? So this is an ego, and superego is my values. So they have an underdeveloped ego. The ego of an thing is not, that isn't not much of a development in such people. And also we all know there is some kind of a defense mechanism which works whenever we are in a stressful situation. So these defense mechanisms are something like an matured or an immature, the way we react to an event. So what happens here is, usually OCD people develop what is called as an isolation, undoing, displacement, or reaction formation. That is, they have an anxiety for a contamination. They want to wash their obsession. If thoughts are so much, they want to undo it. That is, get rid of the thoughts. So they have to do some act. That is in washing their hands. So that is an undoing, isolation. That is an avoidance of the thought. They try so much to avoid the thought. That is not happening. So displacement. Displacement is something like, from one place to another. That is the kind of thoughts are displaced. So these are the things which is, a developmental thing which happens, which, and Freud has explained, these are the defense mechanisms which usually pop in whenever there is a kind of an anxiety symptoms. So learning theory is, as the day goes on, these kind of an starts developing, there is a conditioned response. So whenever there is a vegetable they get from the store or anything, as soon as there is some kind of a traumatic event, or they perceive that vegetable is dirty, it is conditioned by washing vigorously. See, we all wash vegetables, it's a normal thing, but it's a repeatedly which is done, or an intrusive thought where they cannot put it aside. So that we call as an obsessions. So these events, traumatic events, eventually they produce an anxiety and discomfort. For this, they usually have a passive avoidance for this. That is, staying away from the source. You might have noticed there is a difference between an OCD and OCPD. That is a personality, where people like being very clean or putting everything in place. But if they go out or something, it can be left alone. We do not say it in disabling, or it is an interfering with, and we cannot diagnose it until and unless they have some kind of an pathological things which is involved in it. So they avoid, so that is in cleaning bathroom, they cannot touch the phenyl because they feel it is dirty, so they avoid cleaning the bath. So this is a kind of a passive avoidance which they start acting. Is there any wrong in the brain which has circuits in the brain which happens when OCD? It is just not about whatever happened in how we developed ourselves, or from childhood development, or in learning and all those things. Definitely not. See, there is something called as a neurotransmitters in our brain which acts within. See, these depression, anxiety, and all these things, OCD, they are all interconnected to each other. See, as you all notice, you are noticing here, there is a metabolic rate which is a basal ganglia or an orbitofrontal cortex. So you can all see where is the frontal cortex or a basal ganglia. So this frontal cortex is a part of a brain which helps in receiving things, perceiving things, whether appropriateness, or there are different parts of the brain which controls some kind of a work which is assigned to it. It's probably, we can say, it's a main switch. So what happens here is, whenever there is a signal which is perceived, these signals are passed on to the basal ganglia. Basal ganglia then to a thalamus and to the brainstem. So these are the thoughts which are passed to the basal ganglia. Basal ganglia, it is a more richer in a serotonin. These are the neurotransmitters, chemicals which are there in brain. So what happens is, there is an abnormal firing, or there is a deficient of it, which leads to an compulsions, which is a brainstem, which is an action, which is which will lead to it. So these are the things, probably I can explain it in a simple way. So it is ego dystonic, that is usually might be patient perceives it to be kind of not okay with whatever things are. I do not want to think so much. I do not want to do so much, but I'm unable to do it. That we call as an ego dystonic. And he takes more than 1 hour per day. It is something like, taking bath for 3 hours. Okay, so and it has to disrupt his routine. So these are the things which we can call it is a kind of an OCD features patient is having, our client is having. So what are the things which they do repeatedly or in repeated thoughts? Having an foreign contamination, that is fear of contacting some diseases, or concern that there is some germs there, dirt there, or bodily waste like in sweating, or maybe some saliva. All these things might be, they might feel that there isn't it is not okay. Then obsessions with their own body. So obsession with their own body is maybe in a part of their ears, eyes, lip, all these things which is not okay, the current recurrent thoughts, and they keep on checking in the mirror. Okay, so whether it's an right or not. Then contamination, frequent hand washing, so that can go on even 100 times or something like that. So it is not just about the contamination or repeated hand washing, usually symmetry also. That is, whenever some glass is kept, no, it should not be kept in that way. No, it has to be kept in the kitchen. It has to be in the order in certain way only. And slippers should not be kept like this, and it has to be. It is not about how things are kept. It is how distressing if it is kept like that. Is there any intrusive thought like that? So that is what is says patient or a client is having an OCD. Then repetitive behavior or any hoarding. That is, you cannot put anything to a garbage. Everything needs to be kept as, and beliefs are sort of something called as superstitious. If the cat goes on, no, I should not be doing this. Any lucky day, lucky number. Having an obsession to it, can't rid of it, that can be a feature for all these things. So now to say, usually what is an age which we usually people have these kind of issues are, average age of onset may be anywhere from 13, 14 to until 30 or 40. So we need to have a differential diagnosis of whether patient has any underlying depression or body dysmorphic disorder, or any kind of say delusional disorders, all these things. Then when we clinically diagnose it or an assessment is done, then we can say patient is having, or a client is having an, yes, this is what is known as an OCD. So one treatment aspect, if we are talking about, one is the pharmacological treatment where the medications are needed, and OCD is one of the disease where non-pharmacological therapy is considered to be a monotherapy, or what is called as an, initially we can start doing a CBT or an ERP or a mind coach, having and implementing a mind coach, or anything might be there. So these are the non-pharmacological therapy where patient might not need a medications, but still patient can, it can be started with the treatment. If we have to start with the treatment, so how do we take in the client, or how do we do that? So one is detailed assessment is very much needed for the patient, because as I told, is there an underlying depression or an underlying any other causes? We need to rule out that first, and then detailed clinical assessment as any other formulating of any psychological issues, what we do. So it is the same protocol which is followed. But, and also there are certain rating scales or VIVOC rating scales, for probably, or checklist or severity assessment. These are all very much helpful in a clinically when we are assessing the patient, because there has to be some objective assessment of the issue, whatever the problems he's coming with. So when the client says, I'm washing my hand, and which is causing an amount of distress, see, whatever the distress I have I might be scaling it in a different way, or the person with the client might be scaling it in a different way. So that is why these rating scales are very much important. And I would want to say, and this thing about the CBT in detail, I think probably you can have a much more elaborate input in whatever the NHCA Singapore CBT courses, and it is very kind of in depth. It is actually they teach in depth. So that is one thing which we need to say. And psychoeducating the patient. Client needs to be for any mental illness, for that matter, psychoeducation is very, very important. So what is that psychoeducation we are talking about is, see, most of the time clients say client might say, see, I wash vessels. Once the maid washes the vessels, for example, I wash it 3 times. When you ask, why do you wash 3 times? Client might say, I feel it is distressing. I mean, it is dirty. That is why I wash. So you need to understand why is that, what makes you do that. If you do not do, what happens? So my client might feel it is normal for her, or my family members are kicking up a fuss about it, or client might themselves say, I do not want to do it, but still I am compelled to do it. So this, regarding this psychoeducation and telling in detail what is an OCD, what are they suffering with, they usually have this kind of an notion that, this is how I am. This is my personality. I am a perfectionist. This is my personality. I would want to say it is not one's character or something like an unresolved conflict where you cannot fix up anything. No, it is not like that. So clients have most of the population have a kind of an misconception. So we need to understand here that if there is a distress or to complete a task, more number of hours if it is taking, then I think it needs to be addressed. And also we need to explain them what is the link between the obsessions and the compulsion, and what is that distress which is causing. Distress in the sense, what is that distress which is happening to them? So is it something like, the patient, where the client is unable to do it and can't hold it? So it becomes very difficult for them to, when they visit visit some their friend's house or anything. So is it something like that? So this is what the link between, whenever they have thoughts about the obsessions, there is always a link between, they would immediately have to go and wash their hands or keep things arranged. Is this something like that? Then explain the biological and psychological basis. This is very important. If not, patients will usually have a dropout. They do not understand where things are coming. It is only like, you're telling something as a therapist and they are not able to receive it. So because it is nothing like, we have a much of a knowledge about the physical health rather than, we do not have that much of an understanding about the mental health issues. So that is why biological basis, what is this? It is very important for the patient and also for the clients and also the bystanders or the family members, for them to understand this. And also initially to discuss their course outcome, whether it's in long term or in whatever things. We usually have this kind of, whenever we also go to visit a doctor or anything for our illness, we also ask it's quite a natural entity. So, I mean, how many days do I have to take this tablets, or how many days should I be visiting you? How many, open discussions is always helpful. It is not about, patients have to be told that is the outcome. It might not be, it is very premature to tell whether it is, I can take 1 month or you will be amazing person after 1 month. No, that is not possible. Realistic approach is much more better. And it's quite a long term where you need to be coming for a different sessions, and we would be working out what we would be doing, and expressed emotions. That is, having family members together as a co-therapist, or this is very, very important. And family support is also might be a very important in this, because usually they are always branded, always they are told that, you always do this, this is what you are. Usually long term the patients are not supported by the family members. So if it is kind of I'm starting with a CBT. Okay, see, this is all the thing which we have. I have, I have studied during my DPM or an MD days. But the thing is, having a practical approach to the patient is very, very important. So that I think I must say that I should really be, thankful to Dr. Mittal for having an amazing sessions on the CBT and also mind coach, where it had given me a clear scenario or a vision about how to approach the patient, what is that I need to be doing, and how to go about with the sessions and all those things. I think probably this is just a gist of about what is that we would be doing in an OCD, rather than you would be maybe if you're enrolling, you will be learning more about what is a CBT and how it goes on. Okay, so whenever we start with the sessions, we have to decide on whether we are taking the medications, we are telling the patients to take the medications, or it is only the a kind of only the therapy sessions which is we are implementing on the patients. If at all patients opts for no, it has to be CBT, or it has to be only the medications or something. So the studies have shown that we have to explain to the patient that along with the CBT, if we are doing also the medications, it has an amazing outcome. So the outcomes are always better. Initially starting with maybe a list of an obsessions. What are the obsessions? When the client comes to the doctor, usually they say a couple of things which they think it is important to them. So it is very important for us to understand that we have to say what is that they want. Okay, so hierarchy on whatever the things are, whatever their obsessions, what is that they can make a list of it. So for that, VIBOC rating scales or a checklist is very, very important, because there are n number of obsessions which may have, like from a magical thinking that, for example, if I don't do this, if I don't cross the road in this way, probably something might happen to my family members. Or if I don't write it in such certain way, or if I don't do this, I don't put this glass to the wash basin. So this thing, something might happen to them. So these are called as what is called as a magical thinking, and the patient might not actually acknowledge it or not think that is a problem. So having a list of an hierarchy is very important. What is its content, frequency, what is the duration, what is an amount of interference, and how much distress is it causing, or how many times is it they're taking, and what are all the compulsions which they're taking, is there any triggers, or do they avoid it? What do they do to avoid deal with the problems? So these are all the things which is very, very important. So then coming to which we all very well known, it is an ERP technique which we follow. So there are a lot of other things which, see, most of the time what happens is the patients here, as I already told, OCD is an anxiety disorder. So most of the time patients are either are not, clients are not ready to come to the sessions, or they think, okay, so how much long does it take, or that amount of anxiety is there in all the spectrum. So relaxing the patient, or see, it is nothing clear cut that it has to go in a behavior therapy or an ERP or sensitization. It's nothing like a protocol. It can be customer made. First, you can apply some few of the techniques in a mind coach, like in a balloon technique or in cord cutting. All these things might be included, and it can be custom made, and then it can be, you can take the patient, client into a confidence, and then you can start with the session. Like exposure response prevention, where we call, so you can model as a therapist, what you can model as anxiety the patient is having in any discomfort. So you, if at all, for example, if he is having a contamination for an phenyl or anything, or touching it, for example, putting a client also, therapist also puts on the hand and shows, see, nothing has happened. So prolong it for a few hours, then actually making him realize that, see, nothing actually happens, that you can still avoid your anxiety. So these are all the various things which we can actually inculcate. So when whatever the catastrophic fears he is having, that something might really go wrong, or this is the end of it, those kind of an anxiety will be definitely reduced. And with an ERP, which is a very well known, it is in 75% of the patients would show a tremendous improvement with that. See, these are the whatever I have highlighted in the red. These are the energy ball technique, cord cutting, EFT. See, these are the technique which we have been taught. I have been taught by Dr. Mittal in a mind coach, where I actually implement this along with whenever I am taking in between the sessions, or before the sessions and all these things, and alternate sessions when I do. relaxation technique. This has helped me in a lot more to keeping the client in a relaxed manner, to make them realize, yes, this is all the part of the therapy, and also this is the outcome is much more better than what is expected. Like what we all know as a therapist, cognitive restructuring. We know there is an irrational things which is irrational thoughts which goes on in a patient's mind, where kind of an I am bad. I'm for having such thought. I'm a very bad person. So there is always an automatic secondary dysfunction which comes in. So these thoughts has to be replaced by what is that by core belief, identifying his core beliefs, and converting it to an what is an alternate or what is an app, these things. So at the end of it, probably would be discussing if it is an imagining my baby is stabbed, these are kind of an obsessions which a mother gets all the time. So what is the cognitive restructuring can be done? Okay. So the next coming is a systematic desensitization. See, as I already was telling you all that it need not be kind of an A, B, C, D. We need not have to go in the same kind of an track for each patient. It can be customized or it will be tailor-made. So in this way, relaxation training or relaxation technique, which I follow to my clients, which I have learned from a mind coach Singapore, it is very, very helpful for the patients or the clients to relax, and kind of an cognitive hypnotherapy which we follow, or in kind of an whatever the things which we subtle things which we've been taught practically, applying on ourselves, and these things have helped so much in the it need not have to be only a JPMR or which we read it in the books. Okay, so I think it's been an amazing journey for me, and still it is going on. Then usually in the systematic to say, if we have to follow these 3 steps, then relaxation training, hierarchy, and desensitization of the stimulus. In relaxation training, as we have learned, it's a progressive muscle relaxation, where in every book gives in a manual that it has to start with the muscle relaxation and yoga, breathing, and tape recorded, a guided meditation, and mental imagery, and all these things. Yes, of course, but before, we should always remember that clients are having a spectrum of an anxiety disorder. If we do not relax them, if we do not teach a relaxation technique initially, I think the trust between the therapist and the client is all gone. So therefore, it is very important to have and implement these kind of techniques in between, so that they are much more better, and then there is much more an understanding between the therapist and the client. So next, coming to hierarchy construction. So client might say, I have 10 obsessions or compulsions, but when you have 10 obsessions or compulsions, how much is distressing? Is it the 10th one distressing more, or the first one distressing more? So therefore, hierarchy constructions is very, very important. Like 10 to 12 in order to increasing your anxiety. So that you can sensitize them in a graded manner, like from the lowest causing an anxiety to the maximum of an anxiety. So systematic desensitization or a stimulation is nothing but you are first relaxing the client, and then you are telling the hierarchy constructions where you are having a minimum or to a maximum of an anxiety, where you are exposing them to that, and you're desensitizing these clients to to these kind of an exposure. It can be in vivo or in vitro, that is in kind of an imagery or something like that. So flooding is also one kind of an CBT which we have been taught that it is an graded exposure, where kind of an if the client says no, I cannot touch the phenyl bottle, it's 100 kind of a thing which you are taking him to a bathroom and telling him, okay, fine, we will do, say nothing is happening here. So an extreme amount of an anxiety he is led to, and he is stopped, patient to, there is no escape for the situation. He will find it very hard. So we need to choose which kind of clients will be fitting into it. Okay, so they experiences the fear and which they gradually subsides over the time. Then again, what works better to whom, it cannot be told. What works better or what is the first one to be followed, it cannot be told. And again, it needs to be with every client, it is a different. Thought stopping is one of the technique where in thought stopping, the patients are stimulated, they're given an stimuli for an obsessions and they are made you're stopping them. No, you stop with an no, you're not washing your hands. Okay, so one thing is here, what happens is you are giving an aversive therapy to kind of an for his compulsions or for his thoughts. So, and also there is one more technique in this thought stopping is where, you tell the clients to postpone the thoughts until a specified time. It is not, you should not do that. Like for example, if she wants to wash her hands or wants to wash the clothes, you say, if you have this kind of an obsessions now, probably the urge, you should let it build, the urge might build. It is okay if you wash your clothes after 4 hours. So you're giving a timeline, specified timeline here. So in this way, it is much more now the clients are helped in managing their own, how do they manage an anxiety or an anxiety provoking thoughts. Okay. See, one thing at this note, I would want to tell you is, see, it is not an adjective, OCD is not an adjective to be used at all. Okay, I am kind of an OCD person or something like that. People who have are really, it is very, very distressing where the other person cannot understand them. It is not possible for another person to understand what they go through. It is just not a kind of a personality issues or anything. Okay, so I think they genuinely need some help, or they may have to make an understanding about the insight about what is wrong and what needs to be done. And for this one, I think in handling patients and giving a therapies, I think NHCA Singapore has brought an amazing kind of an input in it, and I have inculcated most of all of the techniques here to, most of the clients whom I take for a therapy, and it has helped tremendously. Okay, so I can say that. So no matter it is in CBT or in kind of an EFT or a cord cutting and all, where relaxing the patient at one go is what I have learned. Because initially when I started my therapy sessions or techniques, I used to follow as everyone does. We have a manual and we need to, I used to read a lot and inculcate all these patients. But I started realizing, something somewhere is missing. It is not that the client you would drop out, or client would say, no, I'm not okay with this, still I have these kind of issues. They would always come back. But now I have understood what is that I need to give, because we, as a therapist, they come with when the client come with a problem, it is a solution what they are wanting for. So I think in this regard, I think that is what is needed, and I think it has helped me a lot. Okay, so I would end my session here. So any questions or anything, you can just, yes, Shrija Jawar has one this thing. Madam, can you just type, or I would stop sharing the. Yes. Yes. Okay. See, what is the timeline to decide about an OCD? According to the criteria, what we follow in ICD-10 or in DSM, what we call as a clinician. Okay, so what we follow is DSM-4, DSM-5, it says around some maybe a 6 months or so. But ICD-10, we say 1 month of, kind of a very distressing and have patients is clients are having an anxiety along with an OCD symptoms, or you are having an Vibox scale says distressing of more than a 20 scales. It is shown. Then we say it is, the patient clients is having an OCD. Okay, so I have a, any other questions? Can please type in the chat box. It can be reflected in other behavioral aspects. See, it can be. See, hand washing, didn't we, in a COVID times, how many times we have been told to hand wash, isn't it? Whenever we go out, come back, and we are hand washing it. So we are repeatedly doing it. So see, one thing is, whenever there is a distressing thing which happens to us, or it is an overcold. I've seen many people having an eczema out of their hands. So that is creating and disabling. If the person spends more than an hour in a single act, doing anything repeatedly, that we call as an OCD, or having an kind of an, we can actually call it an OCD symptoms. Okay, so Deepali is asking me, what is OCPD? OCPD is one of the personality disorder, what we call. People who have, kind of a personality where obsessive compulsive personality disorders. It's a personality entity. So to say whether OCPD personality are more prone to go to OCD, it is nothing a dictum of it. Okay, so it's a personality entity where patient feels that it's a part of their personality. Keeping my house is cleaning is okay for me. It is part of my personality. I keep everything clean. I keep everything arranged. It's a part of personality. But when you call it as an OCD, that is spending more amount of time, or if you do not do an act, if I do not clean, if I do not clean mop my house a day, I have an urgent work to go. So I can always say, I can always come back and do the work. Okay, so that is an adjustment which I'm doing. If I'm not able to do that, then it is called as an OCD, where I cannot relieve that anxiety. Okay, so organic component, yes. I think Dr. Sunita is the one who is asking functional disorders, or yes, madam, amazing. This is, we have a substance abuse. People who take a cocaine, who have a cocaine withdrawal. So these people have a kind of an obsession. They start having an obsession, a part of an hallucinations, or whenever there is an space occupying lesions in a frontal lobe. So I have been referred with a patient who says he is around some 70-year-old women who have been referred. They say family members got there, where they say almost about 4 to 5 hours she has a mop in her hand and she keeps cleaning everything. She says there is a germs there. Okay, so when we evaluated, and that is why if we call is the mental illness, that first we need to rule out any other comorbidities exist. So that is one thing. So having a space occupying lesions or in tumors in the brain, or substance abuse, all these things might cause an OCD kind of an symptoms. Is cleanliness an example or its mandatory symptoms for OCD? Impulsively can also come here. Yes. See, most commonly what we see, there are several obsessions which client might have, a person might have, or a patient might present. But cleanliness is most commonly found. People might not have a cleanliness as an obsession. It is something called as a blasphemous, is what we call. They go to temple and they have an intense kind of thoughts that, I might blurt out something bad. Because God is something we consider to be an eternity, where we fear the God and we need to be following certain rules. But a person, when he enters the temple, as soon as he enters the temple, he has an intrusive thought to scold the God with a bad word. This is also an obsession, and this based on this obsession, he cannot enter the. He tries to avoid going to temple. So this can also be an OCD symptom. So that is why I have always been emphasizing on white box scale is very, very important for us to kind of know what are all the type of obsessions. Sending WhatsApp messages impulsively, yes. See, anything which is kind of an should not have a gratification out of it. If you're having a pleasure out of sending these kind of an messages or anything like that, that's a different thing. And having an have kind of a distress about it, that is in one aspect of it. Differential diagnosis of OCD and OC personality disorders. Yes, one is having an insight and ego dystonic or ego syntonic. Okay, so ego dystonic in the sense having a kind of a distress or enjoying. Some people have a habit to do things, isn't it? So that we cannot call it as an OCD unless and unless we have it's a clear kind of a thin line between what we diagnose. If someone has a habit of hoarding wrappers, empty boxes, bottles, okay, so anything in a bin, is that OCD? Yes. See, one thing, I think it's asked by Natasha Chowdhury. Okay, so Natasha, let me answer this. Having this hoarding of an wrappers, empty boxes, bottles, or anything, this also symptoms happens in psychosis, where you might have seen people, having in psychotic symptoms, having everything in their this thing. Why do they do that? That is again a therapist view needs to be that is what we need to explore. What happens if you do not do that? What happens if you try to throw the box? If the big client says, no, if I try to throw the box, what if I want sometime? Have you used this? So many boxes are there. Have you used any time? No. I might feel that, sometimes I might need it. Okay. So do you think it is all boarded? There are so many dirt in it and all those things. Do you think it is okay for you to be like this? No. If I throw it, I don't know. I kind of sense of have some kind of a very jittery kind of feeling. This explains, yes, he has an OCD and not a psychotic features. Okay. So what are the early symptoms that can be identified by the person or their family members? Shivakami Natasha. Okay, let me answer this. See, early symptoms where, before the client identifies themselves that there is something wrong, I think people around them can identify there are repeated behaviors which they are doing. See, thoughts we cannot emphasize. We cannot get into someone's person's thought, what they are thinking. But only thing is their actions we can know that they're doing it. And do you think any normally who would sweep their house 4 times in a day? Who would take 3 hours or 4 hours to take a bath? Okay, so these are all the things which is an early symptoms a client might think. Okay, I had a patient who would have a proxy compulsion of make her husband also, to take bath 4 times. So these are all the symptoms which we can say, yes, this is an early things which symptoms which we can identify as. Denial about OCD of cleanliness, how to make a person realize that he has OCD. Yes, most of the patients can have a loss of insight. They might feel, I am okay, I am normal, I don't feel anything, but we need to emphasize on the anxiety part of it. It is not about the compulsion. So we cannot pitch in on the compulsion, and we cannot pitch in trying to say, oh, you have a problem, you come to me, I will solve it. No. Patient has been brought, we need to be very kind of and relax him and say, okay, so this is what is happening. See, you have an anxiety, you have a problem. Do you think if I can relieve this anxiety? Do you think things can improve? Can a trauma or an event lead to OCD? Subhida, you're asking that. Okay. So one thing is, if the person is a kind of an has an OCPD personality. See, already I was telling kind of a personality which they have. any event can trigger. See, it is we were talking about the psychoanalytical and part of it, where Freud has told, whenever we have, you might have seen a children, when you scold them, they might start sucking their kind of thumb or something. So they have a regression to that. So at this point of it, they can have this thing. What's the maximum and the minimum recovery period for OCD? No, that cannot be told. So usually we have a protocol that any therapy for that matter for an OCD might take 1 year of a time, where also a maintenance therapy also is required, where the patient is taught how to handle all these things. Can only therapy help or medications are needed for the most, Deepali? Yes. In an OCD, CBT is considered one of the monotherapy for mild to moderate amount of kind of thing. Difference between flooding and ERP. See, exposure response, it's a graded one. Flooding is all of a sudden, like in a flash flood, what we have seen, kind of, you just expose them to maximum anxiety and there is no situation out. You give them a bottle of phenyl to hold them, which causes an utmost anxiety. In ERP, what you're doing, a drop by drop you're putting on the head. First, initially, you will tell them to imagine and all those things. These are the things which need to, I think we will follow that. If a person is too religious, spends too much time for the religious practices, is this an OCD symptoms? See, it is one of the things which is called, we cannot call it is to be an OCD or something, and until and unless we consider it to be, most time, as I again and again I've been telling, he spends most time doing it. Okay, one is having an insight. Again, treating the client, yes or no, putting in whether he has an insight, he needs to be doing all these things, whether not only religious practice, OCD cannot be to only segregated to one segment. Usually when we get into the deep of the OCD symptoms and how to take about, how to manage the client, usually they have multiple things. Say repeating prayers, Manpreet is asking, as a repeating prayer is OCD. I'll tell you an example where one of my client, she walks into the hall towards the bedroom. They have a puja room. She has to recite a mantra there multiple times. It is not a single time, but multiple times. Whenever she has to go in, come out, go in, come out, it is, she's reciting it multiple times. So here, to call in OCD, we have to ask the client, what if you do not do? What will happen? Say, for example, you enter the room and you do not recite a Gayatri mantra. So what happens? She says, no, if I do not recite, something might happen to husband. What might happen? No, he might lose the job, or there might be a threat to life. That is what we call as a magical thinking. That is what needs to be corrected here, rather than not about what her beliefs are. Okay. What if a person is having an, okay, Sonal is asking me, what is, if a person is having an obsessive thought that everyone will leave him alone, is it an obsession? There are shared obsessions. Okay, see, like we have some kind of a custom set home, right? So slippers needs to be only at a slipper stand. You cannot wear it inside the house. So these are the things which is being followed. That is why, kind of, it is very subjective. What we call as an OCD, it is not for everyone. That is why I was telling it cannot be used as an adjective to anyone, right? I am kind of an OCD person, or he is an OCD. We cannot call that. And we cannot brand anyone to have an OCD. So that one thing we have to. Okay, I think I will take up last two questions. Are OCD and tic disorders linked, and can one trigger the yes? Yes, definitely. Shavlini, having a tic disorders is one of the differential diagnosis. Okay, like, blurting out, there was some Rani Mukherjee's movie, I do not remember, Hitchki. Okay, I think you would have, seen it. Amazing acting she did. So here what happens is, you must have observed, whenever she's having an anxiety, her tics bouts. Okay, so it's an obsession where it's an entirely different entity, and tics also is a treat. I mean, kind of it can be managed when there is an anxiety is to the minimized. Okay, so deep brain stimulation is helpful in this. Definitely, I think it's transmagnetic stimulation is Dr. Avanti. There is one thing what is called as a transmagnetic stimulation, which we usually do, where the electrodes are put, or it is in the brain, or in we subject them to then transmagnetic stimulation, where it is an under the sessions, different sessions are taken to them, and weekly 2 to 3 sessions are given, where that part of brain, as I was explaining you, that is why to know the anatomy of the brain, where the problem is arising, is very important. Where the frontal brain is more stimulated, or the basal ganglia is more stimulated, where serotonin, we are made to release the serotonin, which controls this kind of thoughts, is that is what we do. Anything else? Okay, so I think we would be running out of the time. So it's just in 1 minute left. So I will just take this last question of Manpreet, where she asks, hair pulling is OCD. It can be a part of symptoms, and there is something called as trichotillomania in psychiatry, where they have an impulse of pulling the hair. Okay, so impulsivity, whenever they have it's called as an impulse. See, we have to differentiate here. Hair pulling gives a kind of a gratification. If it gives a gratification, it's not OCD, right? So I have already told you why it is an OCD. So if it is grieving something, kind of a wow pleasure thing, pulls the hair, that what happens in a trichotillomania, where they have an impulse urge to pull the hair, they feel wow. So this usually happens in the children most commonly. So if it is an OCD, it should not be pleasurable. It should be very distressing, kind of an anxiety. Okay, so I think we have come to the session, the last minute of the session. I would like to thank Dr. Mittal for this thing, and anything else we would kindly please share it in the WhatsApp chat or anything in the group, whatever the other queries you have about the maybe anything handling the clients, or about the course or anything. Okay, so I think it's a vast, maybe.
We'll cover more topics by Dr. Pavana, as well as question answer sessions. So that was one of the most interesting session today. And OCD is a topic close to everyone. Maybe 80% people they face some of the other symptoms, either anxiety because of certain things, or such a minor obsession, or they might think that they have OCD sometimes. So that's why this topic was very interesting and wonderful. Thank you, Dr. Pavana.
Thank you, sir.
Who are interested to know more about the Mind Coach program, they can WhatsApp me separately. And we do not have group for the students. We do not do that because the privacy we have to respect. Because some are very juniors and some are VIPs. Some are practicing doctors. So we don't want some young one to come and send forward messages and spam. And we respect the privacy. We never create the WhatsApp group. So whatever is required, you will get the auto messages from my WhatsApp account, as long as the number is saved. Okay, and keep attending the sessions as per your schedule. Monday is for child and psychology counseling, and Wednesday is for marriage counseling. Friday is for business aspect sessions, mentoring, and Tuesday and Thursday is for Mind Coach. We will open up more sessions. We'll start more. I will inform you. Thank you, everyone. Have a great time. The CBT will disclose later. Thank you.